Good evening. This is Dr. Chris Montville from Tennessee Fertility Institute. Thanks for joining us on our December Facebook Live. We have the distinct honor this evening of hosting or visiting with Dr. Tiffanee Lenzi. Dr. Lenzi works with Tennessee Maternal Fetal Medicine, and she's going to visit with us today in a conversation about recurrent pregnancy loss. Thanks for joining us.
Thank you.
It's great to have you here. Me. Dr. Lenzi has a stellar background in training. She received her doctorate of medicine at Wayne State University in Detroit. She also earned a PhD in neuroscience from Wayne State before entering OB/GYN residency at Stanford University. She then moved back to Michigan and completed 2 fellowships, one in maternal fetal medicine as well as in medical genetics. So she's board certified in obstetrics gynecology, maternal fetal medicine, and medical genetics. That's a long road, and not very many people can say that they've accomplished those great things. She's a fantastic provider. She's very personable. Dr. Lenzi's been a personal friend of mine for quite some time, and it's just great to be able to share stories about patients and to contact one another whenever we have questions. So we thought it would be a great opportunity to have her join us tonight to answer your questions about recurrent pregnancy loss, but also just kind of give a good overview about how we both approach it, me from a fertility standpoint, but also Dr. Lenzi's standpoint from being a maternal fetal medicine specialist as well as a medical geneticist. So welcome.
Well, thank you, Chris, for having me. And we did train together at the University of Michigan, and that was great. And I'm really happy our paths crossed here in Nashville again.
Absolutely.
So I'm very happy you're here.
Recurrent pregnancy loss.
Yes.
We see a lot of couples who come in who've had 1 loss, 2 losses, 3, sometimes even 6 or 7 losses.
Yes.
How do you define recurrent pregnancy loss? And how do you kind of guide couples through the initial evaluation?
Well, I think it can be defined as either 2 or 3 consecutive losses, and it's certainly reasonable to start the workup after 2 losses. When I start my consults, I divide it up into about 5 broad categories, and you probably use some of the same categories. One is genetic, another is blood clotting or thrombophilia. Third would be a uterine factor. Fourth would be hormonal factors, and fifth, lifestyle and kind of other things.
What ages of patients do you typically see in the evaluation? Is it a mixed bag? Do you see more younger patients, older patients?
I would say I see all ages in my practice. I think we see some young women too. In my maternal fetal practice, a lot more older women. But I think in the recurrent loss world, we do see a fair number of young people.
And is there a number of losses that a patient may have when you really start focusing on a more thorough evaluation?
When somebody comes in with 2 losses and maybe 1 live-born, I'll still definitely do a complete evaluation in them. And then people with the higher order losses, I might start thinking about things that are maybe a little bit less common, lower yield. One example might be things like celiac, or maybe other sort of recessive or other odd genetic things that might run in the family. And I think in those cases, it's really important to do not only the complete medical history, but drawing out a full pedigree, finding out what kinds of things run in the family, who else has had miscarriages, were there any birth defects, or fetal or neonatal losses.
Excellent. Where do you start from a genetic standpoint? I know that you focus both on high-risk pregnancies and maternal diseases, or diseases that a mother may have that may potentially impact a pregnancy. So how do you bring your experience for both focusing on issues like hypertension or diabetes? Are they associated with recurrent pregnancy loss, but also from a genetic standpoint? How do you kind of start to counsel patients through that?
I think an important part of the genetic workup is something I see left out a lot, I think, because it can be an expensive test and people sometimes don't understand testing and how to interpret it, is a karyotype. So couples that have had 3 or more losses will more often have a chromosomal translocation. It's been estimated that up to 5% of couples will carry a chromosomal rearrangement when they've had 3 or more losses. And what that means is they have the correct amount of DNA, but it's in different places than it would normally be. So a piece of chromosome 14 may move over to 21, and that piece of 21 may break off and move over to 14. And for that individual, they're normal, they're balanced, they have the correct amount of DNA, they can make all the proteins that they need to. But when they go to make an egg or a sperm, if they don't give either the 2 recombined chromosomes or the 2 normal chromosomes, they're at risk of having unbalanced offspring.
And for those who are joining us who don't know exactly what a karyotype is, what exactly is a karyotype and how do we determine what a person's karyotype is?
Karyotype, it's a pretty rudimentary genetic test. It's actually just a picture of what your chromosomes look like. So humans have 46 total chromosomes arranged into 23 pairs, the last pair being the sex chromosomes, with XX being a female, XY being a male. And basically, they're arranged into these pairs, and you can take a picture of them and count the number of chromosomes. And then you can look at the banding on the chromosomes just to make sure that all the chromosomes are in the correct place. And again, you can miss subtle things. We won't, with that test, be able to see very small deletions or missing pieces of chromosome or duplications of chromosome. And we certainly can't see the genes that are on the chromosome. So in those 46 chromosomes, there's 25,000 genes. And you can have something as simple as one DNA change, which is like a spelling error, which would not be detected by this. So it's a simple test. However, when you look at early pregnancy losses, frequently it's numerical abnormalities in the chromosome that are responsible. So it is important to look for major chromosomal rearrangements or translocations.
And by numerical, you mean the 1 versus 13 or 1 versus 21?
Yes, or for example, sometimes people will carry a sex chromosome aneuploidy and not know about it. A common one is Turner syndrome, and you and I have shared some patients who are mosaic for Turner syndrome, where some of their cells don't have 2 X chromosomes, instead they have 1 X chromosome, and that can predispose towards infertility and also issues later in life, such as a cardiac aortic coarctation, which if you don't evaluate for that, can in some cases cause major problems.
A lot of what we do with our fertility patients is we counsel them on how their fertility changes with age. How do genes change with age, especially in the egg itself? How do you counsel patients and talk to patients about that?
That's a great question, and a lot of people are worried about their risk of things like Down syndrome. We are at risk for extra or missing copies of chromosomes as we get older. And the risk is really more of a female risk, although that can happen in males. It's not so much an age-related risk. The interesting fact is that to make an egg, there are 2 division processes. They're called meiosis 1 and 2. And the process of meiosis 1 actually begins when you're a 20-week fetus inside your mom, which is really odd. And that egg starts to divide when you're as a 20-week fetus, and it arrests at the time of birth. The division starts to resume again at the time of ovulation, and then it completes at fertilization. So the eggs are in a half-divided state where the chromosomes are sitting there waiting to fully divide into 2 daughter cells for as many years as you are old, actually 5 months older than your actual age.
Wow.
And that's why we think sometimes those chromosomes just don't pull apart the right way. We think it might be abnormalities in what they call the meiotic spindle that attaches to the chromosomes and pulls them to the daughter cells.
That's a great rundown of kind of our genes and how sperm and egg may come together. Are there tests where, say, a couple has a miscarriage? Is there a way that we can determine what the karyotype or what the number of chromosomes is in the actual embryo or the fetus?
Yes, absolutely. I think that's a great question. Traditionally, what we would do is try to get cells from the products of conception, and it could be very difficult to actually collect tissue that's not maternal, that's fetal, and then put it in the correct cytogenetic media, which most surgery centers really don't have. A lot of labor and deliveries don't even have it, and the media can go bad as well. And then send it to a lab, and then those cells had to grow, and then we would take the picture or do the karyotype. And we can still do that, but now there are newer tests out called chromosomal microarrays, or product of conception array, POC arrays. Many companies now are doing this test. And I think the major benefit of these is that you don't have to grow cells. So as long as you have tissue that's not maternal, it's always helpful to send a maternal blood sample along with it to make sure that you're not testing just the mom for maternal cell contamination. They can get an estimate of the number of chromosomes. Another benefit to this testing is that they look up and down each chromosome for tiny missing pieces or extra pieces, deletions or duplications. And that doesn't really increase the yield a whole lot over the 50% abnormal that we expect. I think the major benefit is the majority of the time we can actually get a result.
We also work with companies, or there are companies around that can do reflex testing. Can you tell me a little bit more about that too? Say a patient had a miscarriage and had a DNC. How can you look, even if it was 2 or 3 years ago, can you still look at that tissue to
Yes.
see if there were genetic abnormalities?
Yes, that's a great point. A lot of companies now can take an older specimen from a slide, even one that's been formalin fixed and in paraffin, and that's not something where in the past we could take that and get living cells, obviously, but now we don't need living cells. I have sent that off on a number of patients. I think the limitation with the really early losses is that sometimes the slides are just not enough DNA.
Is there a number of miscarriages that a patient has to have before you start looking into the karyotype of the products of conception from, say, a D&C?
I think that's a great question. I think after probably the first loss, most people probably don't have chromosomes checked. But after 2 losses, I think it's probably a good idea. I think, for one thing, if you find a chromosome abnormality, you found a cause for that loss. I think finding a cause is helpful for a lot of people just for emotional reasons. Secondly, if people go on, unfortunately, to have higher order losses, it's very helpful to know what were the chromosomes and even what was the gender of those babies that were lost. Because that person, to me, who's having maybe recurrent losses with a number of them being something we would expect, like a trisomy, is maybe in a little better category than someone who's had a full workup and we still don't know why they've had losses.
One of the reasons we're starting talking about genetics first is because I often counsel our patients that abnormal chromosomes within an embryo or a fetus is the most common reason for miscarriage. How common is miscarriage because of genetic problems?
We think that about 50% plus of miscarriages are due to genetic abnormalities, and it's usually due to an extra or missing copy of a chromosome. And for the reasons we talked about before, a lot of times it's advanced maternal age and those cells don't pull apart the right way. There have been some other recent studies doing the array testing on larger numbers of pregnancy losses, and there are some duplication deletion disorders that may be associated with these losses as well.
If a patient has a miscarriage because of a chromosome issue or a genetics issue, does that increase her risk to have another chromosome issue with the very next pregnancy?
Very good question again. If somebody has had a trisomy or an extra copy of a chromosome, Down syndrome would be one example of that. It's trisomy 21. We think that the risk is increased for future abnormalities, and it's about a 1% risk until the age-related risk exceeds that, which is about age 38. So when I see those people and counsel them, I automatically put them at that 1% risk instead of the risk that they might be at based on their age.
Excellent. Are there any other points about the initial genetic evaluation for miscarriage that you think we should talk about?
The only other thing that sometimes I like to know, and this can be done with either karyotype or array when testing the actual products of conception, is what were the genders of the fetuses. There are some disorders that are male lethal, and I have had patients with higher order losses where maybe 7 losses and 5 were male. And that, to me, makes me wonder about either a male lethal disorder or maybe a Y chromosome deletion in the father of the baby.
Excellent. Do you always check both parents and look at their karyotype in your initial evaluation?
In an ideal world, yes. And karyotypes are generally covered by insurance, which doesn't mean that they're going to be fully paid for. It always comes into an insurance discussion. So frequently fathers have high deductibles. They don't go to the doctor. The test is about $900 and they typically don't want to spend it for maybe about a 2% probability. But if people go on to have additional losses, I do encourage that test in both parents.
Excellent. Let's kind of move on to some of the other issues surrounding miscarriage. As always, if you have any questions, you can always write us on Facebook and we'll address those live and in real time. One of the thoughts one of the issues that I often address with my patients after having the genetics discussion, because it is the most common reason of having miscarriages, are potential anatomic problems with the uterus. I often counsel my patients about possible uterine fibroids, but what are some other things that we may see with the uterus itself that may increase a woman's risk for miscarriage?
I certainly think congenital abnormalities of the uterus, septate uterus, potentially other things like a duplicated uterus, uterine didelphys. And these are tests that I often rely on you as my REI colleague to help with.
So the way that we evaluate a person for any kind of anatomic issue, there are a couple different tests that are available, but each of them have different accuracy. Probably the most sensitive test, meaning the test that we can pick up errors or abnormalities without much cost, and also in an in-office setting, is something called a hydrosonogram. Some people call it a saline infusion sonogram or a saltwater test. We start out with a transvaginal ultrasound to look at the uterus. That way we can see if there are any fibroids present. And then we put a small catheter in through the cervix and start to inject saline. And that saline will then dilate and open the uterine cavity up. So if there's anything inside the uterine cavity, we can determine if there's scar tissue or a fibroid or a uterine septum. We can also add 3D technology onto our ultrasound, so we get a three-dimensional image of the uterus. And that can be really, if you look at the different studies, about 98% accurate pickup rate. For some of my patients, if we do think that they may have a septum on initial testing, either with a test called an HSG, if they've had it done in a prior office, or even on this hydrosonogram, kind of the gold standard for imaging is an MRI of the pelvis. And that can really tell us the difference between, say, a uterine septum, a uterine didelphys, where you have two horns of the uterus. There's something called a unicornuate uterus, as well as a bicornuate uterus. All of these different changes in the uterine cavity will increase a woman's risk of having a miscarriage, and some of them are surgically repairable. A uterine septum is where the uterus on the outside looks most normal, but there is a septum of tissue in the middle of the uterus, and that can be fixed surgically through an outpatient surgery called a hysteroscopy. And that can really help improve overall chances of having a live birth. Depending on which study you read, it can reduce the chance of miscarriage by 30 to 35%. In terms of your practice, is there one test over another that you recommend, hydrosonogram versus an MRI? Tell us a little bit about kind of the risk of miscarriage with some of those different issues that you see with, say, like a didelphid uterus or a bicornuate uterus.
Well, I think the risk of preterm labor may actually be higher in a septate uterus, even though you would think an entire duplicated uterus may have higher risks. And what we typically do when we have those patients in our practice is monitor their cervix. We don't typically offer cerclage just for that alone, but I think it definitely warrants cervical monitoring. And if we do find a shortened cervix, which often precedes preterm labor, then we can offer progesterone.
Excellent. That's the uterine cavity.
I have a question for you.
Oh, you do?
Uterine
Okay.
cavity. So fibroids are very common.
Yeah.
At what point do you like to remove fibroids in people that have had losses?
Excellent question. So fibroid tumors of the uterus are typically benign tumors that grow in the muscle or the myometrium of the uterus. And there are three different places where fibroids can grow. They can grow on the outer surface of the uterus. We call that a subserosal fibroid. They can grow within the muscle of the uterus. We call that an intramural myoma. Or the ones that really cause the most problems with miscarriage are submucosal fibroids or submucosal myomas. That's where they start to grow within the muscle, but get closer and closer to the uterine cavity, and they can start to displace the cavity. And we often find that in women who have symptoms, which can be anywhere from spotting in the middle of their period to really heavy periods, or an increased risk of miscarriage. I try to explain it that it's as the embryo tries to implant on top of a fibroid, the placenta can't form very well. It can't form very good vascular connections, and that way the fetus can't grow appropriately. If you look in general, any fibroid in the uterus will potentially decrease the chance of a live birth and may slightly increase the chance of a miscarriage. We use the term relative risk. That's just a way to kind of say, what's my increased chance of having a problem? A relative risk of 2, for example, is a 2 times increased risk. So the fibroids that are within the muscle of the uterus, those women have about a 1.2, 1.26 relative risk, so a little bit higher chance of having problems. But those submucosal myomas have over a 2.0 relative risk, so twice higher likelihood of having a miscarriage. The question of whether or not to do surgery really becomes the question of where the fibroids are, and also the size. So if there is a submucosal fibroid that's at least 1 centimeter or larger, we can again do an outpatient surgery called a hysteroscopy to resect that fibroid. And then most couples can try to start achieving conception within 2 to 3 months after that surgery. There are more involved surgeries though. Oftentimes fibroids aren't alone. There are often many fibroids in the uterus. And sometimes we then may have to do an open incision called a laparotomy. Sometimes fibroids get really large. I've taken out fibroids that are 18 centimeters or the size of a watermelon. We recommend surgery if they're about 5 centimeters or larger. And And that's because we do think that they may cause problems as the uterus grows with the developing pregnancy, and that can lead to increased risk for preterm labor, preterm delivery. We also have the ability to do laparoscopic removal of fibroids. And that still is a really in-depth procedure, but it's typically only 4 incisions. And then people can go home the same day of that surgery rather than having to stay in the hospital for 3 to 4 days afterwards. If you do have a big fibroid surgery, though, we typically recommend waiting at least 6 months before you try to achieve conception again, just to let that uterus heal up as well as it can, because there is a very small risk of that scar rupturing in pregnancy as the pregnancy develops. One of the things that I counsel my patients on is that their OB/GYN doctor will often tell them, make a recommendation about when they would potentially deliver. What are some of the recommendations that you make of when to deliver after a big fibroid surgery?
It depends. If it was a very extensive dissection, like similar to what would be like a classical C-section, where we're entering the active segment of the uterus more towards the top or the fundus, our group will often deliver at 37 weeks, which is term, after a course of steroids.
Mm-hmm. Other things that we know that may impact both fertility and may slightly increase the risk of miscarriage is something called an endometrial polyp. Lots of women have polyps. Lots of women do fine with polyps. They're quite common. We see them about 10% of women in our clinic. But our recommendation is usually if they're about anywhere from a centimeter or larger, especially if they're causing symptoms. And in our IVF patients, we recommend removal of those polyps. Again, I think the nice thing about our specialty is a lot of these surgeries can be done in an outpatient setting. We really do think that they help improve outcomes.
Great.
So that's number 2.
Mm-hmm.
Number 3, and one that I think there's a lot of confusion, are the thrombophilias or blood clotting issues. Really, there's a pendulum that's been swinging back and forth in terms of medical literature and recommendations made by doctors for really the last 30, 40 years. Treatments that we used to recommend in the past, even 10 years ago, are now no longer recommended. But we have a lot of patients who come in with a lot of lab testing that can be really confusing. Can you walk us through what a thrombophilia is?
Sure.
Are they really associated with recurrent loss? Are they not? What are some important tests and maybe some important treatments that you talk to your patients about?
Absolutely. So the thrombophilias or blood clotting disorders, there can be ones that you're born with, in terms of inherited thrombophilias, and ones that you acquire throughout life, and those can kind of go up and down, be more or less active at different points in the life cycle. The ones that are definitely associated with early loss and even later pregnancy outcomes are the antiphospholipid antibody acquired thrombophilias. And the labs that should be done to test for that are anticardiolipin antibodies, and usually it's 2 different types, the IgM and IgG type, a lupus anticoagulant, which does not mean that you have lupus, and it is not an anticoagulant either, but that's how it behaves in the test tube, and then a third called beta-2 microglobulin. And because those things can go up and down over time and can also increase when you're ill or in other circumstances, it's important to check those over time. You're really supposed to check them over a 12-week period in people that have had 3 or more early losses, or people who've had severe pregnancy complications at less than 34 weeks. I will say, though, that because they can go up and down, if somebody has maybe not had a persistent lupus anticoagulant, let's say, and they've had several losses, I think it's reasonable to treat them with baby aspirin and Lovenox without waiting the 12 weeks. And frequently people are ready to get pregnant or already pregnant, and it's just not practical to wait. The ones where I'm less likely to treat are the ones that we're born with, or the inherited thrombophilias, and those would be the most common factor V Leiden, which about 5% of Caucasians have. The prothrombin gene mutation, it's sometimes called PT2210. It's just the gene abbreviation. About 2% of Caucasians have that. And then there are other ones that are more common that probably have a far lower risk of thrombotic outcome, and that's MTHFR. Remember, Monday, Thursday, Friday. It's a very long name for an enzyme that's involved in folate metabolism, breaking down methionine into homocysteine. So if your enzyme is not working, you can build up homocysteine. Folate helps that enzyme work. So the treatment for it is folic acid, about 1 milligram. So I think there's no harm in treating with folic acid if somebody has MTHFR. I don't know, however, if it's causative of these early losses. The data does not seem to bear that out. And even with the other thrombophilias, earlier literature would find associations, which do not necessarily mean causation. And when you go looking for things that are common, you're probably going to find associations just because things are common. If you add up all of the thrombophilias, you count MTHFR in there that 10 to 15% of people have, then you're getting into a 15 to 20% chance of somebody having a thrombophilia.
So say that again. How common is MTHFR?
MTHFR, it's an enzyme, and you actually need 2 abnormal copies for the enzyme not to work. Just in general, when you have 1 copy of a functional enzyme, you typically are normal. So 2 abnormal copies would be a homozygote, or what we would consider affected. And those people may be at risk for high homocysteine. Now, the American diet typically gets enough folic acid because our foods are fortified. So most people, even who have 2 copies, have a normal homocysteine level. Now, if you look at people who have 1 copy of it, this is an extremely common disorder. 50% of us have 1 abnormal copy of MTHFR.
50%.
50%. So to me, that's a population polymorphism. Now, MTHFR may have meaning in terms of later in life risk factors. There may be some correlation with atherosclerotic disease, especially if homocysteine is high. There have been implications of that in depression. So it may have other roles in health, but I don't think it has a major effect on early losses.
There were 2 hallmark studies performed that were published in a journal that we call the Green Journal that really took a look at this and kind of settled the debate for most people. And those came out about 8 years ago, looking at both factor V Leiden and the inherited thrombophilias and also the MTHFR issue. Most expert consensus guidelines now recommend that MTHFR not even be a part of the recurrent loss evaluation. And the reason I think that that's so important to discuss is it is common. 50% of Caucasians will have one of the mutations. But a lot of the questions I get is, what kind of folic acid should I be on? Are there really major differences? And I think it is important that what Dr. Lenzi said, that it may be associated in later life with increased risk of heart attack, stroke as people get older. But really, most studies looking at recurrent pregnancy loss do not have an association with MTHFR. Is there a difference in folic acid?
I think that metafolate may be a little better absorbed than typical folic acid that we can get in the store, but it can be expensive. So Deplin is one that people write. I think it's $60 a month. And that's a lot of money when you're on a budget, or if you might be saving up for IVF. So the ways to get around that are potentially to do a higher dose of the folic acid, and some people recommend 4 milligrams. The typical dose is 800 micrograms or a milligram in the literature, or you could monitor the homocysteine levels.
So you mentioned that antiphospholipid antibodies, lupus anticoagulant, the beta-2 glycoprotein 1, and the other anticardiolipin antibodies. If someone does have those and they have a history of loss, what are your typical recommendations for treatment?
Especially if they're persistent, I do recommend baby aspirin, which helps both the maternal and the fetal side of the placenta, as well as Lovenox.
So you do add Lovenox?
Yes. And if they've had a clot, like a deep vein clot themselves, or a strong family history, I might even do high-dose Lovenox. If there's no family or personal history of clotting, I'll probably just recommend the low-dose daily, 40 milligrams.
Excellent. Any other thoughts on the thrombophilias that you tell your patients, or other important key things that may be misunderstood about thrombophilias?
Then I can think.
We got it. Okay. Next, hormones. That's kind of where I come in. Lots of hormonal disorders can cause problems and increase a woman's risk of having recurrent pregnancy loss. Thyroid disease is one of the more common. Women who both have overactive thyroid or hyperthyroidism as well as hypothyroidism are at an increased risk of having miscarriage. Even in a woman who may have a normal thyroid stimulating hormone level, that can be anywhere on the assays that we use from, say, 0.5 up to 5.5. Typical recommendations from the Endocrine Society, as well as the American Society for Reproductive Medicine, recommend that we keep the TSH level less than 3.0 in women who have either recurrent losses or if they have a protracted course of infertility. Those are always important labs if you go to talk to your family doctor, or if you come in to see a specialist like Dr. Lenzi or myself, where we can get those records. We would treat a TSH of 3.5 to try to get it down a little bit lower. So that's one instance of a hormone level that may be normal for most people. But pregnancy is such a challenging metabolic process that we think that if the thyroid may not be able to keep up with that might increase the risk of having a miscarriage. Other hormones that we think as fertility specialists are important are tests called ovarian reserve screening tests. If a woman has a lower number of eggs that we would otherwise expect to see, we think that that may be helpful in counseling them in terms of how healthy their ovaries may be and whether or not they might benefit from some fertility therapy. Now, the data to suggest that that may actually help with recurrent pregnancy loss isn't as strong as some other studies, but we do think that it may help with estrogen and progesterone production. But there can be lots of women who get pregnant in any age range, 20 to 40, where they may have some changes in those numbers. If your doctor is recommending those, or if you've had a specialist that recommend them, the important thing is those numbers don't tell us if you will or will not get pregnant, but it does kind of give us an idea, kind of a window into a woman's biological clock, and to help us potentially with treatments. Other hormones, if women have abnormal menstrual cycles, prolactin, elevations of prolactin may cause problems with miscarriage. And I often check vitamin D levels. People in Middle Tennessee, it's cloudy a lot. Michigan, where we used to live, cloudy a lot. Absolutely. Lots of vitamin D deficiency. So we always want to make sure that if a woman is vitamin D deficient, which is defined as a vitamin D level of less than 30, that you either take an over-the-counter supplement, or sometimes if it's really low, sometimes you'll get a prescription for 4 weeks to take a vitamin D. So if you're in a position where you're either trying to get pregnant or if you had miscarriage, I think it's very important to get a vitamin D checked at least once a year.
I agree. I have 2 comments too. The thyroid, as you know, can change over time. So frequently people will come in and say, oh, my doctor checked that. And as you said, we use different cutoffs for people planning a pregnancy. So frequently what would be considered normal might not be optimal for pre-pregnancy. And it can change over time. So 1 year, someone's thyroid might be normal and they come in the next year having trouble with fertility, and maybe it's not. And I think optimizing that is important.
That's a great point.
And vitamin D, I also think should be at the higher levels of normal. There's not good randomized control trials of that in pregnancy complications, but there are a lot of association studies of low vitamin D levels and increased complications of pregnancy, and people with the higher levels in the 60 to 80 range have a lower risk of those.
Awesome. So we've now talked about genetics, uterine cavity, thrombophilias, and hormones. What are some other things that you tell patients if, say, you've done a really thorough evaluation, you've looked at those 4 different issues? What are some things that you tell patients either to give them hope or give them more realistic expectation of kind of what the next steps might be?
I think that's a great question. People come in, they want answers. They want to know if this is going to happen again, if they're ever going to be successful. And especially people that haven't had a live born, they're just very defeated. And it's good news, bad news. The bad news is we may not find an answer. I'd say about 50% of the time we won't find an answer, even with a complete workup. But the good news is the majority of couples go on to conceive. And I've been doing this for 10 years, and I would say the majority of people really have gone on to be successful. And the figures that I quote are about 75% of couples with 3 or more consecutive losses and no prior live born will go on to have a baby.
That's right. It's a really important point. And one of the things that we talk about is because these chromosomal issues can be so common, because they are random typically, we encourage patients to just keep trying. There's an important grieving process with a loss. It's a loss of a pregnancy. It's very disheartening. And I always encourage our patients to try to grieve as best they can, and to always remind them that we're here for them in any way that we can be. It's certainly not easy. And I think it's one of those unfortunate instances in life where it's such a secret and such a private thing that people don't talk about it much, which is certainly understandable. What about the psychological impact of miscarriage? Do you think there's benefit of counseling? How do you kind of recommend moving forward from that aspect?
I think there can definitely be a benefit of counseling, and I think as providers, not just us, but even primary OBGYNs should be sensitive to the fact that this is a loss. And as a mother myself, I know you bond as soon as you find out you have a positive pregnancy test. Sometimes it takes dads a little bit longer, sometimes not. And like you said, people sometimes aren't telling people they're pregnant, especially if this has happened a number of times. They're going through these early pregnancies. Sometimes they fail. And even when they do open up to people, they say, oh, it's just a miscarriage. It was really early. And to them, it's still a loss of a baby. And I think being sensitive to that is important. And I think sometimes just acknowledging that to them, I think, is enough. Other times people really are struggling and do benefit from some counseling.
At what point will you see patients? Oftentimes I'll have patients ask me, when would be a good time to go see a reproductive endocrinologist or maternal fetal medicine specialist? Is there a set time when you would say, do this and that before you come see me? Or do you say, come on over and we'll talk? How do you approach that?
I say, if you're interested in having the conversation, come on over and talk. I think all women should talk to a healthcare provider if they're thinking about getting pregnant and find out what their risks are. And I think that could be your primary care doctor, your primary OBGYN. And I think people that have either had fertility issues or losses or other medical disease would benefit from having a conversation with a specialist before getting pregnant, because the best time to figure out problems is before.
Absolutely. There's no golden rule about when you should talk to a healthcare provider if you have questions. It doesn't matter how many fancy diplomas they have on the wall. That's one of the best things about our job, is that we want to help people in any way that we can. And so whether if you've never been pregnant before, if you've had 4 or 5 miscarriages, I think information and knowledge is power. And it can be very empowering to help patients and people approach challenges with every new day. I always try to encourage our patients to take things one day at a time, but I really reinforce what Dr. Lenzi said about 75% of women who have 3 or more losses will still end up with a baby. And I think that's really empowering and really encouraging. Fertility and miscarriage rates change with age. So it's important to get in sooner rather than later to talk to a healthcare professional about really how things may change with a woman's reproductive life. And certainly for men. And I think one thing that we always encourage people to do is look at their life choices, look at their lifestyle. We didn't really talk much about this tonight, but getting good sleep, eating a good diet, having alcohol intake in moderation, getting exercise in moderation. There's no magic bullet, but I think really trying to improve one's health. Weight loss could be really important as well. That all those things are important if you're struggling with either infertility or recurrent miscarriage or health issues in a pregnancy.
I agree.
Well, we really appreciate you taking the time to be with us tonight.
I have one question that came through.
We have one question. All right.
Can you say that? Is it possible?
Yes.
Okay.
So we have a question. Can hormone issues with PCOS contribute to miscarriages? It's a great question, one that lots of people have looked at over the years. I have a specific interest in how genes are expressed and receptors are expressed in the lining of the uterus. And so one of the hallmarks of polycystic ovary syndrome is an overexpression of androgen-type hormones like testosterone and androstenedione. And we know that the receptors for those hormones are abnormal in the lining of the uterus. There are more receptors for androgen hormone in the lining, and that can affect both estrogen and progesterone signaling. But most studies that look at the risk of miscarriage do not show a significant increased risk of having a miscarriage. One of the problems with PCOS is actually just getting pregnant. So there are lots of problems with actually releasing the egg and then potentially with implantation of the embryo. But once we think that the embryo is actually implanted, there's not a great significant risk of having a miscarriage because a woman has PCOS. Historically, if you look at the literature, maybe about a 3 to 5% increase, but it's not going to be like a 20 or 30% risk overall. With PCOS, we really do encourage people to watch their diet, especially carbohydrate intake, and try to try to limit those drastic changes of those hormones as best we can. But the vast majority of women, if they have PCOS, once they do get pregnant, typically do really well.
And I would add to that, if you have any glucose control issues with PCOS, it's very important to control those before pregnancy, because the fetal organs start to form the day of a missed period, and that's a very critical time for embryo formation. You want to have a normal A1C and have normal blood sugars going into that.
Do women who have uncontrolled diabetes have a higher risk of miscarriage?
They probably do in the very poorly controlled diabetes. But even with diabetes that's just suboptimally controlled, they may not miscarry, but the risk of fetal malformation start to go up. And later in pregnancy, the risk of fetal loss, which sometimes can be sudden, definitely is increased.
Any other questions? No. We're just talking to our associate, Jenny. Any other issues,
No.
questions you think we should address? Awesome. Well, thank you so much for joining us. We really enjoy doing these Facebook Live events. Tell us where your offices are for Tennessee MFM. Where can people find you?
We have 4 offices, Nashville, Franklin, Murfreesboro, and now in Mount Juliet. We have 5 doctors and 3 nurse practitioners who'd be very happy to see you in preconception or recurrent loss counseling.
We work together a lot. I often recommend that if our couples are having issues, have health issues that may affect a pregnancy or a past history of having problems with pregnancy, I give Dr. Lenzi a call right away. And I think that's one of the great things about having such good providers here in Nashville, that we can really have open communication and really work well together. So thank you for joining us tonight. We won't be back until 2018, but we're thinking of some other topics. One would be reproductive surgery. What's the role of having fibroids and surgery for fibroids or tubal problems? Is there still a role of fertility surgery in 2018? And then we always like to try to tie in issues with other fertility therapies like in vitro fertilization. And also, one of the newer things that we're thinking about too is talking about how has fertility testing changed over time. And Dr. Lenzi may be joining us back again to maybe talk about specific embryo testing to look at the chromosomes of embryos. There's some more data coming out now that women who have recurrent pregnancy loss may now benefit from a newer technique where we can look at the number of chromosomes in an embryo before we transfer it to the uterus. And initial studies are showing that that may decrease a woman's chance of having a miscarriage. So that's all exciting stuff that we look forward to talking about in the next year. You can find us at Tennessee Fertility Institute, TFI, or tnfertility.com. Again, Dr. Lenzi is with Tennessee Maternal Field Medicine. Thank you again for joining us. We hope you have a happy holiday.